Good morning, guys. It should come as no secret that the NHS is under-financed, under-resourced, overstretched. Just look at this latest pandemonium about the coronavirus. 1.1 million calls to NHS 111. Scary stuff. Hysteria fueled by the media. So, when it comes to male hormone replacement therapy, you can appreciate it's not very high up on the list. One could argue it should be. If you go to the doctors and you want to transition from male to female or male to or female to male, then of course, no problemo. Here are some hormones. But if you're deficient in testosterone, unfortunately, gotta suck it and see. You'll get better, do some exercise, address your diet, address your lifestyle, you'll be golden. You don't need testosterone, you've got a beard. You've got a child. Look, you've got muscles. So, there's misinformation, misunderstanding, and unfortunately, this is unlikely to change. Primarily for the reasons already discussed, overstretched, under-resourced, It's not high up on the agenda. There are more important things, like the coronavirus. The NHS has to adopt a firefighting model. It wants to adopt a preventative model, and we do realise that addressing causation will affect a positive change and a positive outcome. It would actually save the NHS a lot of money. But we live in a sick society. A sick society that is fueled by the pharmaceutical industry. We go all tin hat now. But there's an investment in keeping us not too well. I'm sure there is. What would happen if everybody was healthy and the pharmaceutical industry couldn't sell all their drugs? You've got to keep those shareholders happy, haven't you? So, private care. It's a necessary evil, in my opinion. We should obviously be able to approach the NHS and deliver and receive gold standard care. But the practicalities when it comes to male TRT, it's not possible, unfortunately. Now, the NHS has to go by it doesn't have to go by, it normally goes by the manufacturing guidelines, because obviously that's where the original research came from, the safety profiles, etc. So to obviously have medications passed by the MHRA, they have to go out strict testing. But when you think about male hormone replacement therapy and you understand the premise behind male hormone replacement therapy, and that's stability, injecting a drug such as Nebido every 12 weeks, Enanthate, Sustanon every 3 weeks, does not, in my opinion, serve in the best interests of the patient when you understand that you want to have stable levels irrespective of the timing of the injection. We've gone over this ad nauseum. I'm a massive fan of daily subcutaneous testosterone cypionate and HCG injections to help mimic natural physiology. This is microdosing, using the minimum effective dose to achieve your desired outcome, to help facilitate physical and psychological well-being, to help reverse those negative symptoms that you presented with. So private practice actually allows me to deliver gold standard care. Why? Well, there is enough evidence behind microdosing. There's science, there's biology, but the GMC are more concerned with evidence. So I wrote a piece called TRT Best Practice, which I'll put a link to in the in the description, which explains the rationalization behind microdosing and the use of HCG with links to relevant research. So private practice allows you to deliver a standard of care service that far outweighs that can be delivered by the NHS. TRT is complicated. I'm not going to lie. So the sledgehammer one-size-fits-all protocols that the NHS offer, they serve a purpose. They're better than nothing, but they don't serve in the best interests of the patient, in my opinion. So what is microdosing from a legal standpoint? Well, it's using a medication off-label, otherwise known as unlicensed. So if you use a medication not as per the manufacturer guidelines, then you are providing that medication unlicensed and off-label. So your clinician, your prescribing clinician, must have the confidence to do that. Now, I'm fully invested in TRT, hormone replacement therapy. Obviously, I've dedicated my career to this field of medicine. I'm constantly learning, and it's super exciting, super interesting. It's also super frustrating because obviously we face resistance, we face barriers, we face haters, but there is a growing amount of evidence and research that supports the way that we practice. And what we're actually engaged in now is a clinical research trial to demonstrate the effectiveness of microdosing. Not only the safety profile, but also to demonstrate the reduction in side effects and complications. To demonstrate that it shouldn't take a rocket scientist to work out that having healthy male androgen levels is healthy. Having stable male androgen levels is healthy. Maintaining function using HCG is healthy. So there appears to be a disconnect, and what we are trying to do is we are trying to bridge that gap and demonstrate to the NHS not only are we offering a wonderful service, you get a nice filtered cup of coffee when you walk in, but our practice is safer, more effective, and it's gold standard, baby. So I alluded to earlier, your prescribing clinician needs to have the confidence, experience, knowledge to prescribe the medications. They obviously have the assurance or reassurance that there are manufacturing guidelines, but as we've already alluded to, that is not gold standard or in the best interests of the patient. So microdosing is 100% the future. We adhere to the BSSM guidelines. However, what we do is we make them more effective. We show more diligence, more attention to detail, because that is the only way of effecting a positive change, in my opinion, to the individual's care. We aim to change practice. Gold standard, baby.